Rashmi Srivastava, MD, Department of Child Health. Fever in infants and children, sepsis, meningitis, and occult bacteraemia. Rashmi Srivastava, Maryland, Department of Child Health. Fever phobia. Fever is the most common pediatric complaint, second only to routine care for clinic visits, and the most common reason kids are brought to the ER. In the Middle Ages, fever was felt to be a marker of death or divine punishment. Some feel true fever is harmful. 1/3 parents thought 38 to 40 degrees Celsius 100.4 to 104 degrees Fahrenheit, 2/3 40 to 41 degrees Celsius 104 to 106 degrees Fahrenheit, and all thought brain damage greater than 41 degrees Celsius 106 degrees Fahrenheit. 5 to 20% of no localizing signs on P with no history to explain the fever. The majority of kids with fever do not have a serious illness, although a small percentage harbor or may develop a serious bacterial infection. True fever is not harmful to a child if the fever is not due to a serious infection and the temperature elevation is not due to excess heat load, defective heat loss mechanism, SNES damage or disease, or excess heat production. True fever occurs when IL-1, IL-6, TNF or other cytokines are released from monocytes and macrophages in response to infection, tissue injury, drugs, and other inflammatory processes, increasing the body's set point. The anterior hypothalamus maintains an inherent set point near 36 degrees Celsius 98.6 degrees Fahrenheit. Normal circadian rhythm, which is highest up to 2 degrees Celsius, 3 degrees Fahrenheit, 6 p.m. and lowest at 6 a.m. This accounts for increased volume of ER visits that peaks in the evening. Most true fevers follow this diurnal pattern. False fever, aka hypothermia, does not directly increase the body's set point. SNES disease that directly affects the hypothalamus, ICH, infection. Diseases that increase the body's production of heat, hypothyroidism, malignant hypothermia, salicylate overdose. Excess heat load, child left in a car or left next to a heater for too long. Defective heat loss mechanisms, burns, heat stroke, drugs that compromise blood flow and sweating mechanisms. Normal causes of temperature elevation include physical activity, ovulation, and environmental temperature. Reliable temperature measurement. All measurements are estimates of the body's true core temp. Central circulation equals aorta and pulmonary artery. Rectal, gold standard. Esophageal, accurate but impractical. Tactile and axillary, inaccurate, varies considerably with environmental temperature. Tympanic, inaccurate and age less than 3 years. Benefits of fever. The hypothalamus will not allow the temp to rise above 41.5 degrees Celsius 107 degrees Fahrenheit. WBCs work best and kill the most bacteria at 38 to 40 degrees Celsius 100.4 to 104 degrees Fahrenheit. Neutrophils make more superoxide anion, and there is more and increased activity of interferon. Coxsackie and poliovirus replication is directly inhibited. Fever without the source FWS. 5 to 20% of febrile children have no localizing signs on P and nothing in the history to explain the fever. By definition, less than 7 days. FWS, like fever, is most common in children younger than age 5, with a peak prevalence between 6 and 24 months of age. Those less than 6 months retain protective maternal antibodies against common organisms, while those 18 to 24 months old are more immune competent, and are at a lower risk of developing bacteremia. Diagnostic assessment in children. Age is important as 1. Etiologic pathogens, 2. Clinical exam, and 3. Immune system capacity changes as the newborn ages. Most break them into the first 2 to 4 weeks of life. Neonatal, 1 to 3 months, and 3 to 36 months, neonatal. P is felt to be unreliable in detecting many serious bacterial infections. Meningitis should always be considered. Up to 10% appear well, only 15% have a bulging fontanelle, and 10 to 15% have nuchal rigidity. So, a high index of suspicion is important. 20% will not have fever initially. Hypothermia or hypothermia. Lethargy or irritability. Poor feeding or vomiting. Apnea. Dyspnea. Jaundice. Hypotension. Diarrhea or abdominal distension. Bulging fontanelle. Seizures. Neonates. The majority of febrile neonates presenting to the age of a nonspecific viral illness. 12% of serious bacterial infections, SBI. Infected by more virulent bacteria. More likely to develop serious sequelae from viral infections. GBBS is associated with higher rates of meningitis 39%, non-meningeal foci 10%, and sepsis 7%. The most common bacterial infections are UT and occult bacteremia. Neonatal early onset less than 7 days, later onset greater than 7 days, group B strep. E. coli. Listeria monocytogenes. Enterobacteriaceae. Enterococcus. Strep viridans. Strep pneumoniae. Haemophilus influenza NT. Herpes simplex. Later onset greater than 7 days. Neisseria meningitidis. Neonatal. Risk factors. Preterm. Membrane rupture, before labor onset or prolonged greater than 12 hours. Chorioamnionitis or maternal peripartum fever. UT. Multiple pregnancy. Hypoxia or APGAR score less than 6. Poverty or age less than 20. 1/3 half neonatal sepsis will have no risk factors. Neonatal. Screening tests. WBC less than 5,000 or greater than 20,000, PMN less than 4,000, IT2, PLT less than 100,000, SHE greater than 1, LFTs elevated suggest HSFO. So, if less than 28 days of age and rectal temp 38 degrees Celsius. Admit. Blood culture. Urine culture, cath specimen. Lumbar puncture. Cell count, protein, glucose, culture, PCR. Parenteral antibiotics. Ampicillin plus gentamicin cefotaxime, consider acyclovir primary maternal infection, ESP if delivered vaginally, PROM, fetal scalp electrodes, skin, eye or mouth lesions, seizures, CSF pleocytosis. Infants 1 to 3 months causes. HOSFOW 17% are 15 days to 6 weeks of age. Bacterial sepsis / meningitis. Group B strep, S pneumoniae, H influenza, N meningitidis, Enterobacteriaceae. Bone and joint infections. UT. Bacterial enteritis ESP salmonella. Pneumonia. Enterovirus sepsis / meningitis July to October. The risk of bacteremia / meningitis is 3.3%, pneumonia, bone / joint infections and bacterial enteritis is 13.7%. 30 to 50% of those who are ultimately diagnosed with bacterial meningitis have been seen by a physician within the prior week, usually 1 to 2 days before, and were diagnosed as having a trivial illness and discharged on oral antibiotics. These children may have had early meningitis that was missed or occult bacteremia that progressed to meningitis. Infants 1 to 3 months. Infants who are toxic and febrile have a much higher risk of serious bacterial infection. They should be admitted, have a full sepsis workup, and given antibiotics / antivirals ampicillin and cefotaxime. Infants who are non-toxic and febrile who meet all Rochester criteria can safely be treated as an outpatient. Generally, 1 to 2.9% of children meeting these criteria will develop a serious bacterial infection, 0.7% bacteraemia, 0.14% meningitis. Infants 1 to 3 months Rochester criteria/low risk criteria. Non-toxic, most critical and difficult. Previously healthy, not low birth weight. No focal bacterial infection on P except otitis media. WBC 5000 to 15,000/3, normal. Bands less than 1500/3, normal. Normal urinalysis, including gram stain. If diarrhea, must be non-bloody and WBC less than 5/HPF. If respiratory symptoms present, normal CXR. Negative predictive value 98.9%. Infants 1 to 3 months. If all of the criteria are met, then there are 2 options for outpatient management. 1. Blood, urine cultures, LP, ceftriaxone 50 mg/kg to 1 gram, and return for re-evaluation within 24 hours. 2. Blood, urine cultures and careful observation. Parents should have mature judgment, can return within 30 minutes and have a thermometer and a phone. If no LP is done, do not give ceftriaxone as it will compromise FU if the patient is still febrile. Infants 1 to 3 months follow-up of low-risk infants. If all cultures negative, a febrile, well-appearing careful observation. Blood cultures negative, well-appearing, febrile careful observation, may consider second dose of ceftriaxone. Blood culture positive admit for sepsis workup and parenteral antibiotic spending results. Urine culture positive, if persistent fever admit for sepsis workup, parenteral antibiotic spending results. If a febrile and well outpatient antibiotics. Heptavalent pneumococcal conjugate vaccine, PCV7 Prevnar. Licensed in February 2000. Routinely incorporated into the childhood immunization schedule in mid-2000. 4, 6B, 9 volts, 14, 18C, 19F, 23F. Recommended for all children aged 2 to 23 months. Invasive pneumococcal disease in children younger than 2 years has decreased by at least 60%. Rates of invasive pneumococcal disease by age group and year. The mean rate of IPD decreased. 0 to 30 days 39%. 31 to 60 days 45%. 61 to 90 days 32%. The rate of IPD among infants aged 0 to 60 days decreased from 7.3 per 100,000 to 4.2 per 100,000. Rates of invasive pneumococcal disease caused by PCV7 and non-PCV7 serotypes in neonates and young infants aged 0 to 90 days by study year. Mean rate 7.3 to 2.4. So what? This data is the first to suggest that neonates and infants too young to receive PCV7 are benefiting from herd immunity. One hypothesis is that vaccinated children are less likely to have nasal carriage of pneumococcus. Infants 3 to 36 months infant sepsis syndrome. Age 3 to 36 months. Fever 39 degrees Celsius. ANC 10,000. If a child meets all 3 criteria, he has a 3% risk for pneumococcemia. If untreated, 3% will progress to meningitis. Bacteraemia risk peaks at 8 to 12 months. Pneumococcal sepsis peaks at 1 year, then drops off. Pneumococcal meningitis peaks at 3 to 5 months. Sinusitis, pneumonia, response to antipyretics, and social status do not significantly alter risk. Other causes, HHV6 15%, UT girls 3%, boys 0.6%, meningococcemia 0.1%, salmonella 0.2%, H. influenza 0.05%, enterovirus July-October. Infants 3 to 36 months. UA with micro, CBC with differential, blood cultures. LP if meningeal signs, not wanting to be held or moved, petechiae, purpura or toxic. Antimicrobials. OM or pneumonia, cover for pneumococcus, non-typable, H. flu and more axilla, amoxicillin plus augmentin, ceftriaxone. URI or no focus, cover for pneumococcus and meningococcus, amoxicillin 80 to 100 mg/dg/day, ceftriaxone. Pneumococcemia, promptly reassess, if well, should at least treat with 1 dose ceftriaxone. PCV7 greater than 97% protection, thus all pneumococcal sepsis will decrease by 90%. So CBC and antimicrobials for this age group is becoming less critical. Toxicity assessment, loss of alertness, decreased activity, irritability, higher fever, sustained fever, anorexia, vomiting, pallor, grunting, and maternal worry. Occult bacteremia. 5% of children with FWS have occult bacteremia. The presence of a positive blood culture in kids who look well enough to be treated as outpatients and in whom the positive results are not anticipated. Occult bacteremia. Streptococcus pneumonia is responsible for 2/3 to 3/4 of all cases. Peak prevalence between 6 and 24 months. Association with high fever 39.4 degrees Celsius or 103 degrees Fahrenheit. High WBC count greater than 15,000. Absence of evident focal soft tissue infection. Neisseria meningitidis, Haemophilus influenza type B, and Salmonella account for most of the remaining cases. Risk of occult bacteremia. Low risk. Age greater than 3 years. Temp less than 39.4 degrees Celsius. WBC greater than 5,000 and less than 15,000. High risk. Less than 2 years. Greater than 40 degrees Celsius 104 degrees Fahrenheit. Less than 5,000 or greater than 15,000. HX of contact with H. flu or N. meningitidis. OB is a low prevalence, so even though WBC is a sensitive and specific screening test, it has a low PPV. So the test does not discriminate between children who have FWS who are bacteremic and those who are not. Therefore, blood culture is the gold standard. Still is a high number of false positives, take 24 to 48 hours, and most cases of occult pneumococcal bacteremia clear without treatment. Occult bacteremia. Empiric antibiotics should be targeted against S. pneumoniae, N. meningitidis, and H. influenza. Amoxicillin. Augmentin, Bactrim, 2nd or 3rd gen cephalosporins. Single-dose ceftriaxone 50 to 75 mg/kg. Follow-up is essential. Oskis Pediatrics, 3rd edition. Harriet Lane, 16th edition. FWS in children 0 to 36 months of age. TCNA 53-2006-167-194. The Febrile Child. Emergency Medicine Reports. September 1995. Antibiotic Choices, The Critical First Hour. Pediatric Annals. June 1996. Evidence-based approach to the febrile infant/child. Handout from Dr. Michael Cooper Stock, MD. May 2000. Advisory Committee on Immunization Practices. Preventing Pneumococcal Disease Among Infants and Young Children. Recommendations of the Advisory Committee on Immunization Practices. MMW or ECOM 2000 49 RA 9, 1-35. ARP, Committee on Infectious Disease. Policy Statement, Recommendations for the Prevention of Pneumococcal Infections, including the use of pneumococcal conjugate vaccine, pneumococcal polysaccharide vaccine, and antibiotic prophylaxis/pediatrics. 2000 semicolon 106 to 362 to 366. Whitney C.G., Farley M.M., Haidler J., et al. Decline in invasive pneumococcal disease after the introduction of protein polysaccharide vaccine. Nangilgent. 2003 semicolon 348, 1737 to 1746. Poelinka et al. Invasive pneumococcal disease among infants before and after introductions of pneumococcal conjugate vaccine. JAMA, April 12, 2006, 295 to 1668, 74.